We're going to quickly review acid-base balance and mostly how to interpret an ABG, so an arterial blood gas. You can have a venous blood gas and an arterial blood gas. They both can give you the pH of the patient. That's not going to change venous or arterial, but we will see changes in like our CO2, our O2, and our bicarb when we have a venous or an arterial. The gold standard is arterial because it's going to give us the best data for how our patient is oxygenating and how they're maintaining that acid-base balance. So, acid-base balance, so plasma pH, so this is the hydrogen ion concentration of the blood. It's how acidic or basic our blood is. Range is 7.35 to 7.45. When we're above 7.45, we're alkalotic or basic. And then 7.35 is our range, and anything below that is considered acidotic. So extra hydrogen ions when we're acidotic, not enough hydrogen ions when we're alkalotic. Our body maintains our acid-base balance through our kidneys and through our respiratory system. So our kidneys do that hydrogen ion extraction, so they're going to pull hydrogen ions out of our blood, and then we just pee it out in our urine. That's why our urine is generally acidic. And our respiratory system is what blows off CO2. And so blowing off CO2 can help decrease in acidosis as well, or we can retain CO2 when we're alkalotic, or we retain hydrogen ions when we're alkalotic. So when we are reading our ABGs first, right, we can think about this as our ABCs as well. So is our patient breathing? Right, so that's how we're going to look at our PaO2. So PaO2 is actually the amount of pressure that oxygen is producing. So the higher the pressure, the better we are able to perfuse that oxygen. So a normal PaO2, So normal PaO2 is 80 to 95 millimeters of mercury, which is different than our SpO2, which is what we want to be greater than 92%. Okay, this can tell us if our patients are hypoxic. It can tell us the oxygen demand of our patients as well. So if it's lower, then we're using a lot more oxygen. Next, we're going to look at our pH. Are we acidotic? Are we normal? Or are we alkalotic? Then we're going to look at our PaCO2. So this is going to tell us if this is a respiratory acidosis or a respiratory alkalosis. Then we're going to look at our bicarb. Is this renal or metabolic in our culprit? Are we having a metabolic acidosis, a metabolic alkalosis? Right, and that's where we're going to identify our origin of our acid-base problem. Okay, what is causing this problem? Our kidneys or our lungs? And then we'll look and see if we have any sort of compensation. Okay, is that buffer system trying to compensate for the metabolic acidosis, right? Are we breathing out more CO2 then? So oxygenation. So again, our PaO2 is going to be 80 to 95. This is the pressure of oxygen. The higher pressure, the better we're able to have oxygen bind to hemoglobin, the more oxygen we're carrying to our end organs. When this is lower, it can tell us either we're not ventilating correctly or we have a high oxygen consumption. So we're using up all of our oxygen from our arterial gas before it can reach right where we drew it from. Compared to like our SpO2, which is just the oxygen saturation per pulse, right? What percentage of our hemoglobin are carrying oxygen? It gives us a good idea of how well our patients are oxygenating, where this can also tell us oxygenation and a little bit of ventilation. So pH is next. That's going to be our acidity level, right? Concentration of hydrogen ions. If it's above 7.45 were alkalotic, because that's going to mean a low number of ions. Anytime we have a high amount of positive ions, we're acidic. So positive ions include our potassium, it includes our sodium, our calcium, and then when we have a high number of ions, we actually have a lower pH, which makes us acidic. So then we're going to look at our carbon dioxide. So carbon dioxide is from our lungs. It should be lower in an arterial blood gas. It might be a little higher in a venous blood gas, right? Because in our veins is where we're carrying CO2 from our cells back to our lungs to be expired. So again, expired by the lungs. A high CO2 can indicate hypoventilation, so our patients who are breathing less than 8 times a minute, or they're not taking really deep breaths, maybe because of pain, or because they have a decreased respiratory drive, say from like narcotics. CO2 retention, which we can see in our COPD patients. Okay, and it's going to lead to that acidosis. We can see low CO2 in hyperventilation. So think of our patients who are super anxious, our patients who feel really dyspneic, our patients who are maybe even like fluid overloaded and are breathing 30 times a minute. They're going to breathe off all of that CO2, which is going to cause them to be alkalotic, so a higher pH. And our range on an ABG is 35 to 45. And then next, our bicarb. So our bicarb is produced in the kidneys. It's going to help regulate our hydrogen ions. So this is when our kidneys bind an hydrogen ion to CO2, which then our body can break down into water and CO2. So we are able to excrete the water through our kidneys, and then we're able to excrete the CO2 through our lungs. So that's how it's able to get rid of that extra hydrogen ions. Again, regulated by the kidneys. It's going to be 22 to 26 milliequivalents per liter is normal. If we're greater than 26, we are alkalotic, and if we are less than 26, then we are acidotic. So see, this is a negative ion, so our negative ions, when we have too many of them, alkalotic. When we don't have enough, we're acidotic. So then we want to identify our culprit organ. What is our problem, right? So check first, our oxygen. Are we oxygenating? Okay, if not, how can we intervene? Do we sit our patients up, put some oxygen on them, okay, increase the oxygen amount on their BiPAP, CPAP, or even their ventilator? Next, we're going to look at our pH. Are we acidotic or are we alkalotic? Okay, how are we going to intervene for such? Well, we got to find out what our culprit organ is. Okay, we can give as much bicarb as we want, but if our lungs are still causing our acidosis, we're going to continue to be acidotic. Okay, acidic or alkalotic, and then which value matches? So we'll look at the tic-tac-toe version here, but if we have an acidosis, what else is acidic? Do we have a bicarb less than 22, or do we have a CO2 greater than 45? Okay, if our CO2 is greater than 45, we're respiratory. If our bicarb is less than 22, then it's metabolic acidosis. Okay, whichever matches our acidosis. So let's say here's all of our things. Oh, that's really bad. So we're going to put our pH here. Oh, hold on, I don't want to do that. Okay. So say our pH is going to be this first one. So pH, it's a bad P. Sorry, guys. pH. Then we're going to do our CO2. Ooh. And then our HCO. 3. And then this is going to be acid, C, I, D, N for normal, alg. Okay. So if our pH is 7.2, okay, and our CO2 is 55, which 55 makes us acidic. Bicarb is 25, so it's normal. So see how these are in the same row? That tells us it's a respiratory acidosis. Now, if our bicarb, say, was 20, and our CO2 was 25, that's going to tell us again we have a metabolic acidosis with some compensation, which we'll talk about compensation here in a second. So again, our example patient here, they are 7.2. Their PaO2 is 90, so we're not worried about that. Their CO2 again is 55, and we're 28. Then we got a respiratory acidosis. I told you guys the normal bicarb is 22 to 26. It is, some facilities use 28. This was a really bad example, sorry. But this is what we want. Okay, so next we're going to see, are we compensating? So uncompensated is when we have an abnormal pH, and then we have only one abnormal, either bicarb or CO2. So we'll have one normal value and one abnormal value. Partially compensated, we still have an abnormal pH, okay, and then but both of our bicarb and our CO2 are going to be abnormal. Okay, we're going to have some sort of attempt to balance. So if we have like a respiratory acidosis, our bicarb's going to be low to try to compensate for that acidosis. Okay, and then our fully compensation is when we have a normal pH, but our CO2 and our bicarb are abnormal. Okay. So again, this is kind of how we can tell if we're compensated or not, right? So fully compensated, a normal pH, and then we're going to have an abnormal bicarb, and then our body is compensating by having like a higher CO2 or an alkalotic CO2. So this would be a good example if this was like 7.4. Okay, and then our bicarb, say, is 18. And then our CO2 is 30. So this is a compensated ABG, right? It could either be compensated metabolic acidosis or compensated respiratory alkalosis. This, so say our pH is 7.7, okay, and our bicarb is 35, and our CO2 is 50. So this is a partially compensated metabolic alkalosis, because these are in the same line, so that makes it a metabolic acidosis with our lungs trying to compensate. They just haven't compensated completely yet because our pH is still abnormal. Okay, and then uncompensated is when we have, again, like a 7.7, okay, bicarb of 35, and then our CO2 is still also only 40. So our lungs haven't done anything to compensate yet. Okay, they're not retaining any CO2 like they are in our partially compensated here. So we have an uncompensated metabolic alkalosis. Okay guys, let me know if you have any questions.